It's great to be here. And this is so when I arrived in Baltimore 12 years ago, someone handed me a crab cake, and this is a normal crab cake on the left. So I've put it in place of the Croque monsieur. But this is if you go to your, say, down marketplace in Baltimore, you get what's on the right. And they tell you once. So Johns Hopkins is not known for it's known for its frugality. So when you retire at Hopkins, the kind of measure of what you've contributed to the place is whether they buy the crab cakes for your retirement versus the turkey club sandwich, apparently. So we'll wait and see. These are my disclosures. So I think this has been discussed a little bit earlier. So I won't go through it in any significant detail. This was a really pragmatic trial. So it's the Pacific, I think, of resectable lung cancer so far. But what I'd like to point out is that so even apart from the fact that patients just got 3 cycles of therapy, they also got less adjuvant therapy. So these patients received a very modest amount of systemic therapy. And so in the investigational arm and the control arm, if you add up all these numbers, I haven't done the figures, but they probably got more chemo overall. And despite this, or perhaps because of this, there was no significant difference in toxicity in the absolute numbers for Nivo chemo in terms of all adverse events, and treatment-related adverse events are lower than for chemotherapy alone. And it's hard to find another systemic therapy trial in cancer in general where when you add another drug to an established therapy, you get less toxicity. Now, this is not statistically less, but numerically it probably is. And again, you look at almost everything. So less nausea for some reason. I'm not sure why that was, maybe chemotherapy regimens, a better appetite, lower levels of neutropenia. So there's several areas where there appears to be less toxicity from adding more therapy, even though this is very modest therapy, 3 doses in total prior to surgery. And in terms of immune-mediated events, which I'll allude to later, in terms of the pre and post-therapy trials, there were almost none. So if you look at the figures here, there was rash in 8% of patients, hyperthyroidism in 4%, and hypoparathyroidism in 3%. Everything else was less than 2 out of every 100 patients you treated. And in terms of pneumonitis, which is one of the concerns with the adjuvant trials in particular, there were 2 cases of pneumonitis from 179 patients, and both of them were grade 2 or less. And as we saw, the results were good. So improved PCR 13-fold and improved event-free survival. And we saw Formula 1 reference earlier. So we'll see this slide a little bit further on where I try to compare between, but this is Max Verstappen, who's sitting here in the middle of these curves. And you can fit him in there, 20% difference at 2 years in event-free survival. And I'm using the 2-year figure here because this is what we have available from the 2 periadjuvant trials to compare. Hazard ratio 0.63. And again, we have an emerging marker of response here. So PCR, it's been referenced in the excellent talk from Dr. Cottrell earlier. But this hazard ratio is pretty impressive, 0.13. If you can get rid of all the tumor by the time of surgery, then you're probably going to do really, really well. And again, which we don't yet have from several of the studies, we're starting to see a curve emerging for an overall survival benefit. And I could probably fit another Formula 1 car in there. A hazard ratio of 0.62, not yet significant because of the low numbers in this trial. So this is about half the size of a GIAN or Keynote 671, but a hazard ratio 0.62, not yet significant. So when I met John recently, John was a senior author on the recent New England paper of Keynote 671. Mariano and myself were treated to his insights. And in Keynote 671, you're talking about a total of 17 or more therapies with pembrolizumab, for example. I'm not picking out pembrolizumab. There is an nivolumab trial, which is going to report out, which also gives 17 to 20 doses of therapy. Comparing this to just 3 doses, which with the 3 doses, we have a short course of treatment, no increase in toxicity, which is measurable at least in 1 phase 3 trial, and much improved efficacy, with the potential benefit of having a biomarker of PathCR and maybe even ctDNA as well. But the conclusion here was to give 17 more doses of therapy and see what happens. So to look a little bit at the other 2 trials, which are the periadjuvant or sandwich trials, where you're giving treatment pre-surgery and again post-operatively. So the hazard ratio from Aegean, which was presented at AACR, is 0.68. You'll see the 2-year, 24-month outcome here, about 11% difference. I'm going to draw in this curve that I had earlier. Hazard ratio 0.63. Now, I'm not a statistician, but that seems lower than 0.68, and lower is good here. And you're seeing at 2 years, 64% of the patients with Nevo chemo after just 3 doses are event-free versus 63.3% in the Aegean trial. A more locally advanced population, perhaps, in Aegean, some stage 3B patients who wouldn't have made it into CheckMate-816. But again, I think the picture tells a story. And perhaps the most important difference here is the difference in toxicity. So when you give 3 doses of therapy, well, toxicity appears manageable. So I'm not the patient, but if I spoke to patients, the numbers might tell a story. When you look at these periadjuvant trials, you do see a small but appreciable increase in significant toxicity. And here, the outcomes of death related to treatment in the durvalumab arm compared to placebo went from 0.5% with placebo to 1.8% with durvalumab. And if you look at the small text at the bottom here, most of these events seem to be immune-related, so pneumonitis, myocarditis. So true events, at least in theory. Again, I'm moving on here to look at Dr. Wakely and Dr. Spicer's recent publication, Keynote-671. So you're seeing here similar outcomes, 2-year EFS of 62% versus 64% in CheckMate-816. Hazard ratio 0.58, which is 0.05 less than 0.63. So that year does something, maybe not. And here, this is the slide really from Keynote-671, which people have jumped on to justify giving 1 full year of therapy. And what they have jumped on really is the bottom part. So in those patients who don't have a pathological complete response, there is some separation between the patients who got neoadjuvant chemo alone, followed by nothing, versus neoadjuvant chemo, Pembro, followed by Pembro, with a hazard ratio of 0.69 favoring the Pembro arm. But I would point out, even when you look at that PATSIOR curve in CheckMate-816, you can still fit a smaller Formula 1 car in between those curves. And it's much smaller numbers. So it's 179 patients, and probably about 75% of those didn't have a PCR. But I suspect if you were to compare these head-to-head in a randomized trial, you may not see a whole lot of difference from the adjuvant therapy. And that's probably what we need to resolve this question. So what I would say overall about this question, do we need periadjuvant? I think we have so many drugs being developed for advanced lung cancer. We really probably don't need more of the same in the adjuvant setting. We need innovation. We need to move new therapies in faster, which Dr. Casconi and others are doing. Just 9 weeks of therapy has a major impact on outcomes, minimal additional toxicity, which is measurable in 1 trial at least, versus 64 weeks of therapy. It's got uncertain benefit over neoadjuvant chemo IO alone. However, clear risks of treatment-associated toxicity, physical, and even mortality. And in terms of financial toxicity, I'm going to mention it once. So I calculated how much time you could spend with Max Verstappen for the cost of 3 doses of therapy versus 64 weeks. You could spend about an hour and a half with Max for 3 doses of therapy, spend the whole day, be driven around Montreal for about 14, 15 hours. So it's a big difference. And I think that's one of the major impacts internationally, maybe not in the US, but internationally, I think that will have a major impact. So thank you very much.